From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to the JAMA Cardiology podcast. I'm your host, Dr. Kristen Patton. I'm a professor of medicine in the electrophysiology section at the University of Washington and an associate editor for JAMA Cardiology. Today's guests are Dr. Gaurav Upadhyay, an associate professor of medicine at the Center for Arrhythmia Care in the section of cardiology at the University of Chicago Pritzker School of Medicine, and Jeremy Treger, an MD PhD who's a fellow in the electrophysiology fellowship program. I want to welcome you both and thank you so much for being here.
Thank you so much. Such a pleasure.
Thank you for having us.
Today, we're going to be discussing a terrific analysis that led to a revision of the definition of what a left bundle branch block is based on direct recordings of conduction along the left bundle branch. This is really exciting work, particularly given all of the new options we have for directly pacing the conduction system. Jeremy, why don't you start us off with a little bit of background about what motivated you to do the study and how it all came about?
Sure. So one thing that interested us and made us want to delve into this was when we looked back as far as how do the current criteria for left bundle branch block, how did they come into being? So you can look at the current criteria and they refer to earlier criteria, which refer to earlier criteria. But at the bottom of the pile, interestingly, is work around the turn of the century, around 1900, that was done largely in canine models. And just as sort of an anecdote that fell out of this, because dog hearts are rotated relative to human hearts in their chests, it actually led to a confusion between what was a left bundle branch block and what was a right bundle branch block based on EKG recordings in humans. And that confusion persisted for a number of decades. And yet this work still underpins our modern criteria for left bundle branch block. And it's never really been validated against sort of gold standard tests to determine how good is it at predicting and classifying left bundle branch block relative to interventricular conduction delay, for instance.
Got it. Well, that really explains why we have so many definitions of what's a left bundle branch block. Gaurav, a lot of listeners are not in electrophysiology. Can you take us through how you map the conduction system?
Yeah, that's an excellent point and is really crucial to understanding how we proposed a modification to the criteria. When we say the word left bundle branch block, we make an assumption that there's block. And the block here that we're talking about is in the conduction system. And our interest was to place a catheter along the left side of the heart where the conduction system emerges on the left side and then quickly branches or ramifies to innervate the whole left ventricle. And that location is just underneath the aortic valve on the left ventricular septum. And by placing a linear catheter there, we can really quickly answer the question, is there block or no block? And so that is where we started, was to see, is there block or no block? And how does this correspond with the surface ECG or EKG recording?
Got it. So you need arterial access for that and crossing the aortic valve with your catheter and the multi-electrode catheter in the septum. Jeremy, how did you decide what kind of patients to include in the study?
So because it involves an invasive study, we decided to use patients that were already referred to our electrophysiology laboratory for invasive procedures. So in particular, patients who were referred for VT ablations or for CRT-D implants. And so because these patients would already be in our laboratory, would already have intravenous or intra-arterial access, we did this study as part of what those patients were otherwise referred to, with their consent, of course.
Makes sense.
Another piece of our motivation, just to expand on a small point, is usually for device placements, we don't obtain arterial access. And we certainly thought about that very carefully for patients who are enrolled here. In this study, at the time of enrollment, there was a surge of interest for a new pacing approach called conduction system pacing. And we had also organized a trial, a pilot study, evaluating biventricular pacing versus conduction system pacing at the His bundle. And as part of the study, we wanted to guarantee to our patients that if they were to receive His bundle pacing for CRT, that it indeed was correcting their conduction block. So as part of that study, we actually nested a different protocol, which was to perform left-sided mapping in order to guarantee that the conduction system pacing was doing the job that we thought it was doing.
And this is really thoughtful and meticulous work. And I'm just going to point out to our listeners that this is not something that is standardly done, even at the time where other centers were working on conduction system pacing as well. However, given the kind of things that we do in the EP lab, it still doesn't seem to be of tremendous risk. Do you have a sense of why it's not done more often, given how incredibly important it is to really understand where conduction block is occurring?
Yeah, that's really well put, Chris. This is actually quite similar to a diagnostic catheterization. A retrograde aortic approach is placing actually a lumenless catheter. So if anything, the clot risk is a little bit lower. And we go retrograde across the aortic valve, which is a pretty common location for diagnostic catheterization. And we do a recording that generally takes between 5 and 10 minutes. Why isn't it performed? I think it's a practice variation from what people are used to. So when you typically do a pacemaker device, you don't get groin access. The whole procedure is typically done from the arm. So I think there is a practice variation that occurs with this approach. And we certainly wouldn't advocate it for everybody. Part of the motivation as well of this study was to come up with an approach that you could use the surface ECG based on the recordings that we had acquired so that we can improve those criteria and maybe save some work for other folks down the line.
Fantastic. So, Jeremy, I don't want to belabor this point. Tell us what you found. What were these main findings?
So our criteria in short form is in addition to current criteria. So it is a complementary criterion to current ACC, AHA, HRS criteria. It is the presence of a notch in lead one, a notch or a slur, and the timing of that notch or slur from QRS onset greater than 75 milliseconds. If you meet that criteria, then our criteria would suggest that it is likely that you have true conduction block, a true left bundle branch block. If you have either a notch time that is less than 75 milliseconds from QRS onset in lead one, or no notch in lead one, no notch or slur, then our criterion would suggest that it is more likely that you have an interventricular conduction delay and, in fact, have intact conduction in the Purkinje system.
Great. So that would mean that any conduction system pacing you do wouldn't correct that wide QRS.
Absolutely correct.
How do you tell the difference between a notch and a slur?
That's also a very good question. These terms are used throughout the literature, and that has always been kind of a sticking point. What's a notch? What's a slur? Two people can look at the same thing and disagree about it. If we were to try and be technical about it, if you were to plot the first derivative of the QRS wave, a notch would have the first derivative crossing zero. In other words, the QRS wave would change direction from a downslope to an upslope, whereas a slur wouldn't. However, that's not something that's necessarily always easy to tell just looking at it.
Yeah.
And the key point of our criterion is that we don't try to distinguish between notches and slurs. We can call it a notch, we can call it a slur. Either way, if the timing is greater than 75 milliseconds, our criterion would accept it as indicating true left bundle branch block. If the timing is less than 75 milliseconds or non-existent, then it would say not left bundle, but it doesn't distinguish between notches and slurs.
Perfect. Oh, that sounds mercifully straightforward. How, Gaurav, did you validate this?
Yeah, so one great piece of advantage we have with the development of newer technologies, particularly trans-aortic valve insertion, so TAVIs or TAVRs are sometimes called, is that there was this natural phenomenon of interval development of left bundle branch block after placement of these devices in a number of patients. And the reason was anatomic. It's because of the struts themselves placing pressure high in the conduction system, exactly where the left bundle emerges on the left ventricular septum. So as a natural model, this is a terrific model for a proximal high in the conduction system left bundle branch block. So our validation cohort consisted of patients who had undergone TAVI, also called TAVR, and had an interval development of a left bundle branch block. And we also examined those patients who started with intraventricular conduction delay and examined whether they would have a change in their morphology as well. So we looked at those patients also. Importantly, and to amplify a point that Jeremy made earlier, these criteria all have variable sensitivity and specificity. And what we found is that the Strauss criterion, which is an excellent criteria, that's another variation on the traditional left bundle branch block criteria, it performed very well in this cohort also of the patients with TAVR. It didn't perform as well in patients who have diffuse myopathic disease, such as in patients with ventricular tachycardia who are being referred for ablation. In that group, actually, the more simple criterion of a time to notch fared better. But
Wow.
for patients undergoing a TAVR, both the Strauss criteria as well as our time to notch criterion demonstrated excellent sensitivity and specificity at identifying conduction block.
It's really great. It's particularly impressive that the time to notch greater than 75 in lead one can be so useful in really very different patient populations. I think that's really critical when you're thinking about who you're going to take to the lab for different kinds of cardiac physiological pacing.
We totally agree. And we like also how simple it is.
Exactly.
It's one lead. And we did look at multiple leads. We looked at no notches, and this performed the best of those different combinations that we evaluated.
And I think, Gaurav, you really talked about this a little bit, but I think just to reiterate for our listeners, why is it that we care so much that we understand the specificity of a left bundle, that we really understand that it's the conduction system that's the problem with a patient's ECG?
Yeah, I think, from the perspective of a general cardiologist or a general physician, the importance here is that the pattern that we looked at, what we look at on the surface ECG, that pattern may reflect heterogeneous underlying pathophysiologies. And a therapy like traditional biventricular pacing may be a better approach in patients who have diffuse disease without specific conduction block versus conduction system pacing, which is a newer approach, which we're studying. There's a lot of excitement. That approach cannot correct disease that is beyond the conduction system per se. The goal of conduction system pacing is to capture beyond a site of block and re-engage the His-Purkinje system. If the His-Purkinje system is working anyway, there's not much to do. So that's the clinical relevance. The other piece of this is that when looking at the surface 12-lead EKG, how can one quickly surmise, is this a real left bundle or not? That was the fundamental motivation. And with notches in particular, it's not simply the presence of notches, but it's also the timing that was helpful. Because what this reflects is the wave break, to get a little geeky electrophysiological, but it's the wave break going from the right ventricle to the left ventricle. At least in our mapping studies, this corresponded nicely with activating across the septum.
And how have you been using this with respect to decisions you make both before you take someone to the lab and when you're in a procedure?
Yeah, so we're measuring the time to notch. Anyone who's got a left bundle branch block, we look at lead one and we measure from QRS onset to a notch. If no notch is present, that is concerning. So we sometimes joke, no notch, no chance for correction with conduction system pacing. Now, to be fair, there are patients with intraventricular conduction delay who have notches. And so it's important to point out that no simple ECG criterion can necessarily encompass all of the complexity of variable patients. So certainly if you have really extensive disease, you can have lots of notches and it all be due to fibrosis beyond the conduction system. That's possible. But the odds of having complete conduction block increase substantially if you have a notch that's late versus early notches or no notches.
That makes a lot of sense. Well, this has been really a wonderful session. I want to check in with both of you and see if there were any other questions I should have asked or points that you want to make for our listeners.
I would just ping off one other point, and you alluded to this, which is, why do we care about ECGs? We always joke sometimes that ECGs are the truth, right? They're showing us something that's going on in the heart. And I think what's been humbling in this whole process is that surface ECG, despite it being around for more than 100 years, is able to give us some meaningful, practical information. Just by tuning it a little bit, tweaking the criteria a little bit, we can get a lot more even out of the EKG. So that's been a pretty cool part of the process for us. And we hope that people keep on using EKGs and maybe also doing left-sided mapping for patients in whom that they want to know the answer.
Yeah, I think that is a nice secondary point as well, that maybe there's a use for doing left septal mapping in some of the patients where you're not really sure what's going to be the most beneficial pacing option for them.
100%. You want to give people the best possible therapy. And in patients where there is uncertainty on that, I think that the problem has been that sometimes we get seduced by a QRS. In patients who have a wide QRS to begin with, we don't have a template of what normal looks like. So for those patients, particularly if they're not going to be getting traditional biventricular pacing, which has been explored, it's very reasonable to think about other approaches to confirm that conduction block is present.
Great. Well, thank you. I just want to thank you both so much, both for being with us here today and also for this really fundamental physiologic work. And I think it's so inspiring that you're paying so much attention to what is a really old diagnostic test and making it better, as you said, and really helping us make healthcare better for our patients. Thank you for coming and being on the show.
Thank you so much, Chris. It's been such a pleasure.
Yeah, thank you for having us.
I'm Chris Patton, and I've been speaking with Gaurav Upadhyay and Jeremy Treger about left septal mapping and a revision of the criteria for left bundle branch block. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.